At Goldfinch, we believe that the best way to treat the opioid epidemic is prevent that first dose. And that oftentimes comes through surgery. Surgery is the number one gateway to opioid addiction. And if you prevent that first dose, you're going to prevent the overdose. The challenges with surgery is that surgery has an opioid problem and opioids has a surgery problem. We're going directly to employers to help their patient population understand the pitfalls of surgery. To this day, over 90% of procedures are more invasive than necessary. You're still far more likely to get a large incision. And this, as I mentioned, is the number one gateway to opioid addiction. Fortunately, there is a better way through surgery, and this goes into my background. My name is John Greenwood. I'm the COO and co-founder of Goldfinch Health. I've spent the last 15 years in the OR learning about enhanced recovery after surgery protocols. I encourage you, if nothing else from this, please Google it. It is the most important thing to happen in the OR since the minimally invasive scope was invented. It's truly revolutionary. And it's all about helping prepare the patient to make sure they're the best version of themselves going into surgery. There are 4,000 articles to the merits of enhanced recovery. They're coming out every day. They repeatedly show a 30% reduction in length of stay, a 50% reduction in complications, and a 90% reduction in opioid use. You can get through major spinal fusion surgery without opioids. It's entirely possible. And we're not asking you to grin and bear it. We're treating you better. We're optimizing going into surgery. So just a quick synopsis on what enhanced recovery is. There's about 10 or 15 of these metrics that all add up in a big way, but I'm going to hit on 3 of them. The first is nutrition. If you know anything about surgery, you go into that operation, you can't have anything to drink the night before your operation. It's been around for 70 years, and it's the exact wrong way to prepare a patient for surgery. It's almost totally unnecessary. We're undermining the patient's nutrition. We're dehydrating them. We're lowering their pain tolerance. We're inducing insulin resistance, which has a number of negative side effects, not the least of which is it inhibits your body's ability to heal the day you've never needed it more. You haven't even started your operation, and you're already behind the 8 ball. Enhanced recovery says there's a better way. Improve their nutrition. It's simple, a Gatorade. Give the patient a Gatorade up to 2 hours before surgery. It's out of their stomach. There's no concern about aspiration, but it reverses all of his other negative consequences. Just as a quick aside, Harvard just did a study looking at just that in total knees and total hips. They gave half a Gatorade, the other half, they had a standard fasting approach. They didn't look at ERAS, that's settled science. They looked at just the nutrition. And they found the people that got a Gatorade left the hospital 33% faster, a full day sooner, just for a 79-cent Gatorade. Equally simple and cheap and revolutionary goes to this opioid component, what's called an ERAS request, preoperative multimodal analgesia. So multiple modes of non-addictive pain medication given to the individual to use opioids as the last line. And the really revolutionary part is before the procedure. When you load the patient up with these non-addictive, very simple generic medications, when they come out of surgery, they don't have that huge crash. You've closed off your brain's ability to perceive that intense pain. And before you know it, you're well on your way to recovery without the opioids, and therefore avoiding the potential for addiction and all of the negative consequences that come with it. We also help advocate for minimally invasive approaches in surgery. In 2021, there's a minimally invasive approach for virtually every procedure. All of that scenario around ERAS sounds wonderful, and it's so well established, it's so well understood. Unfortunately, it's largely an academic pursuit. This is really where Goldfinch comes in. According to American College of Surgeons survey, only 1 in 20 physicians has implemented enhanced recovery. You're not likely to get this on your own. You might ask yourself, how would you make sure you got this experience? I've been doing this with my family who's denied in surgeries just this year. So what do we do to help a patient get enhanced recovery? We deploy our team of nurses at a time that we understand that a patient needs surgery. We reach out to them. We have 83% engagement in an opt-in scenario. We meet them where they are. We help understand if they need a physician. We can help them find a minimally invasive physician who does ERAS with our nationwide network and partners. But what happens very often is that we're understanding through a pre-certification or FMLA paperwork, they already have a physician. And that's where we're rolling up our sleeves, we're educating the patient, we're communicating with the physician, and we're advocating for these best-in-class care protocols that are backed by the best science available. That's why we're seeing incredible results with this advocacy. When we compare our average recovery time, not only do we have less than a 1% readmission rate, but we have over 34 days saved in recovery, a very underappreciated metric about how a patient's ultimate surgery actually went. We compare this to an IBM Watson database through MD guidelines, and we show across the board over a month saving per patient. And as I mentioned before, surgery has an opioid problem. We're able to get 78% of our patients through surgery without any opioids at all. It comes down to education and preoperative pain management. Just put that in perspective, traditionally 76% of patients use opioids after surgery. We're flipping that on its head. 96% of our patients are using none after 5 days, a critical inflection point of withdrawal. And you start to see why 96% of our patients say they absolutely recommend this to a friend or family member. We get glowing reviews. Just as a synopsis, so who are our customers and what's our progress look like? We launched our first pilot with Mutual of Omaha a little over a year ago. Now we have over 150,000 covered lives. Our employers are not the physicians, as you may assume, but we're going direct to employers. We're going to disability carriers. We're going to workers' comp, and we're in turn taking that power of the purse and turning to physicians and saying, hey, now these major employers in the area are aware of enhanced recovery. We're requesting, what are we doing to help provide opioid sparing strategies and ultimately help them usher them back to work sooner? Physicians love it when they get it. We can get into more of that later. But this is truly a proven engagement model. As I mentioned before, when we get that pre-certification report, it's reproducible, it's automated. We're working with some major carriers that deliver it. 83% of the time, the patients want to opt in. And just this last turn of the year, we closed on $1.4 million seed round. This is a truly clinically proven effort. In fact, frustratingly so. We are agnostic to the provider. We can work within your network. It's something that's really proactive about getting ahead of the opioid epidemic. We offer case-based pricing. We per engagement, and we'll put 100% of our fees at risk. It's such an effective results that if we don't save at least as much in recovery as we charge, we'll refund the difference. Never had to do that. We have assembled an incredible team of intellect and experience in surgery and in business. And we are perpetually open for conversations around our next round, as well as advisories and customers as well. Thank you for your time.
Thanks, John. Definitely love what you're doing. And yeah, it's really frustrating that surgeries aren't already all happening this way when you hear what you have to say. A couple of great questions already coming in. Andy Geese asks, how do you convince the anesthesiologist to change their protocol? The behavior change with physicians must be a big hurdle.
Yeah, no, it's a great question. The number one we get. And the reality is that a lot of times we, with our script, we've tailored this to address the opioid epidemic first. 80% of patients are concerned about opioids. Only 20% talk to the doctors about it. And when we confirm with the patient that they're concerned about opioids, when we reach out to the physician and anesthesia, we say this, in our communication, they have concerns about opioids. What can we talk about what we can do to minimize the need postoperatively? And we talk about generic medications. We have a deep emphasis on being on equal clinical stature with the physicians. Oftentimes we know the studies better than the physicians because that's what we live in. And when you start with that very low hanging fruit, you start opening up larger talks about preoperative anti-nausea medications and liberal fasting guidelines. And frankly, anesthesia is very open to this. They're oftentimes doing this in other specialties, just maybe not the one we're working on. So they'll say, hey, it's good for the colorectal procedure. Why not for the hysterectomy or the knee replacement?
So we're a little tight on time here. There is a question, when are you raising again? You just raised, right? But you said you're always open for conversations for the next round. Do you have any timing?
Yeah, we're in some late stage conversations going into 1/1 we're very excited about. So our presumption is that early this spring to rise to meet that occasion. We'll be back there for a Series A.